Spider veins and reticular veins are often considered only an aesthetic topic. First of all, to really understand which is the right treatment to offer to our patient, we should deeply understand the pathophysiology. Here's a slide from the last Vein in Venice Professor Gennaro Quarto speech about pathophysiology.
It can be hypothesized that the pathophysiological mechanism underlying the telangiectatic dilation can be over three types. Reflux coming from the sub-hypodermic venous segments, and we can call this extrinsic mechanism. Reflux generated by alteration of the hypodermic adipose layer, and we can call this an intrinsic mechanism. And reflux generated by alteration of dermal hypodermic support structures, and this is another intrinsic mechanism. This can give us the knowledge for the use of other complementary techniques in the treatment of telangiectasis.
Then another point is to deeply understand for sclerotherapy that we consider the first line treatment, which type of sclerosing agent we should use, which are the difference between the sclerosing agent and which are the effects on the vein wall. Here you have an highlight from Professor Bozkurt's speech of last Vein in Venice symposium.
Actually, we can divide in three groups. Irritants, these are directly cytotoxic drugs. Osmotic agents, directly cytotoxic, and detergents, they are less cytotoxic, but they cause intercellular connections. Regarding the irritant solutions, we have ethanol, phenol, and iodine, but we are not using none of them currently for the treatment of C1 disease. We do use sometimes osmotic sclerosing agents. They do cause a concentration gradient between the endothelial cells and intravascular space, and it then cause fibrosis. Hypertonic saline is the most commonly used one, and glycerin is the second one. HTS is a low toxic profile, and actually there is no risk of anaphylaxis, but it may cause, injection of the drug may cause some pain, muscle cramps, or sometimes hyperpigmentation. We mostly use detergent sclerosing agents. These cause protein denaturation and at the end disrupt cell membranes, and the effect starts in minutes. We have sotalol, STS, polydecanol, muriate sodium, and ethanolamine oleate, but most commonly we use STS or polydecanol.
Also, we often talk about laser treatment, but which type? Transcutaneous laser treatment or the use of some fibers? Do you know what endoperivenous laser treatment is? Which are the possibilities that you have in the treatment of reticular vein with this technique? Here's a really short highlight of my speech of last Vein in Venice. As you can see in this short video, you can punch directly the vein with the fiber or with a small needle and then insert the really slim fiber. In this case, it was a 200 micron fibers. With the near infrared system of visualization, you are able to see during the treatment the occlusion of the reticular veins. And but really most important thing is to remember to do a good skin killing skin cooling, that you can do with ice package with specific devices possible. And this is the results immediately after the procedure. As you can see, just small hole in which you insert the fiber. What you see after the treatment sometimes is some blood trapping that you can drain with the needle, but after 4 to 6 weeks, you will see the results, and if you plan correctly the procedure, you can achieve for reticular veins really good results. For any kind of treatment, we should follow evidence-based medicine. So also about this topic, we should have some guidelines that recommend us which kind of treatment and which kind of patient and disease to choose and to offer. This is a point that was really highlighted and touched by Professor Gianesini last year. Here you have.
Not based on the methodological flows. I kindly disagree with terms like should be considered. What does should be considered means? You see, for example, for patients with telangiectasia, where treatment is planned, sclerotherapy should be considered, but also transcutaneous laser should be considered, 2AA, 2AB. Doesn't mean that I have the patients in front of me, I see the legs, and well, I'm considering that, but okay, I don't care, I do something else. Is it recommended or not? With this kind of recommendation, I disagree also because I think we have a lot of literature showcasing that still good sclerotherapy in good hands remain the main action we do for our patients. And I disagree with the fact that CLaCS is a new option, as it was written in the guidelines, because I showed you 2003 publication, so it's 21 years ago.
Spider veins and reticular veins treatment are a vascular treatment that should be performed by physician trained and by physician that deeply understand which is the pathophysiology, which kind of treatment we can offer to our patient, and also the indication after the treatment. So it's my pleasure to invite all of you at the next Vein in Venice to discuss about this beautiful topic, to hear from you, from your experience, and to share knowledge.